because we are all searching for answers, because we dare to believe that together we will beat this. Thank you for joining us here today. We have people participating in this summit from all over the world. Some of those in this DC audience are Josh Perry from Raleigh, who survived a brain tumor, who now uses his pro BMX and stunt background to raise awareness. Sarah DeBoard, a colon cancer survivor, who teaches young adults about the warning signs. Mike Paradowski, a cyclist who after overcoming head and neck cancer, now rides 500 miles each year to raise awareness. Joe and I are so grateful that you are all here with us today. We were so proud when President Obama asked Joe to take mission control of the White House Cancer Moonshot in 2017. But when the administration ended, we really hadn't planned on launching a cancer advocacy organization. But many of the leaders we worked with through the Moonshot told us, there are incredible organizations in this space. They are doing good life-saving work, but there's still a need for someone who can bridge the gaps. Cancer experts, friends, and colleagues recognized Joe's unique ability to convene, form collaborations, and hold people accountable. We felt a moral imperative to step up, and we were honored to be joined by a world-class board of directors and advisory council. They've done tremendous work, and I'd like to take a moment to thank them. Together, we've been hard at work on improving data standards and helping patients share their data, reducing disparities in cancer outcomes, calling for greater access to patient-centered clinical trials, and changing our culture so we can make the best use of investments. Today's science has us at an inflection point in cancer, and we must seize this moment. I was in my early 40s when a close friend of mine named Winnie was diagnosed with breast cancer. Soon, another friend confided in me that she had breast cancer as well. Then another, then another. In 1 year, I watched 4 friends face down cancer. 3 of them survived, but Winnie didn't. I couldn't forget the looks on the faces of her children. Winnie's death motivated me to get more involved in this cause. I hated knowing how many women would die because breast cancer was something that was only whispered about. So I went to what I knew, education. In 1993, I started the Biden Breast Health Initiative. We wrote a curriculum for girls in high schools about self-examinations and prevention. And over the next few years, we visited every high school in the state of Delaware. In the 25 years that I've been working on cancer, a lot has changed. Thanks to many of you here in this room. In fact, according to the American Cancer Society, the cancer death rate has fallen 26% from its peak in 1991. Yet, as you all know, progress is uneven. Rural, Black, Latino, and Native American communities all see far fewer positive cancer outcomes. Poverty Poverty draws a line between surviving and succumbing to the disease. Cancer is the second most common cause of death for children up to age 14, and cancer rates for this age have actually increased over the years. While earlier diagnosis, precision medicine, and immunotherapy have revolutionized the treatment of certain diseases, many cancers still remain as deadly as ever. And though improvements in diagnosis and treatments can change the statistics, individuals still struggle to understand and cope with the complicated medical environment. Patients and their families too often feel overwhelmed by medical jargon and treatment options. They feel alone and confused by the complexity of the very healthcare system that is there to support their journey. All of this is not for lack of trying. There are wonderful organizations doing incredible work in this area. Many of you are part of these organizations. But the gap that exists between scientists, patients, advocates, and nonprofits are still untenable. Despite decades of research, billions of dollars in funding, and the best minds in science working on this issue, there is still no word as frightening as malignant. But all of these advancements only matter if they actually improve lives, your lives, the lives of your family and friends. That is the guiding principle of our work at the Biden Cancer Initiative. We're bridging the gaps in the cancer network. We're working to provide resources, improved outcomes, and just as important, provide hope. What does that all mean in practice? Right now, if we stopped all the research entirely, if we never spent another dime on finding new cures, we could still save thousands more lives by doing one thing, breaking down the barriers between the various branches of this movement and sharing the knowledge that already exists. Over these last few months, I've convened community dialogues around the country with family members, nurses and doctors, patient navigators, and other care providers to share their perspectives on the cancer journey. Through these conversations, we've heard about the realities of living with cancer, ways to support caregivers, and how navigation impacts and drives outcomes. That knowledge has informed our Biden Cancer Collaborative, a platform that brings patient and advocacy organizations together to develop solutions to these problems. Our hope is to use this collaborative to develop a roadmap to navigate this disease. Today's summit is about sharing, finding solutions, imagining a better way to redesign the cancer experience. Today, we will hear from speakers across sectors, disciplines, and backgrounds who are connected by the cancer experience. We will explore solutions to some of the most complicated problems and challenges standing in the way of progress. We'll listen, learn, and hope together. Across the country, conversations are occurring in nearly 450 community summits. In each one, individuals are coming together to contribute what they can to solve the problems facing cancer patients in their communities. And throughout the day, you'll hear about the public and private sector's commitments regarding cancer. For example, it may not be obvious what the sharing economy has to do with cancer, but as you will hear this afternoon, Airbnb, WeWork, and Lyft all found ways to support this effort. But it's not just big groups, it's individuals who are making a difference as well. During one of my visits to Portland, Oregon, I met Kristen Nelson, an oncology social worker who is here in the audience today. She told me about a young cancer patient whose treatment was working, yet while he was recovering, he was losing weight. He eventually confessed to her that he was on a very fixed income. He lived in a modest apartment with no real kitchen. He had a hot plate that he used to cook, but it had broken, and he could only eat food that didn't need to be cooked. So Krista helped him replace the broken appliance, and his recovery got back on track. When we think about the tools to fight cancer, not many of us would include hot plates. But to this young man, that's exactly what he needed. Everyone has a role to play. So go to your strengths. What can you bring to this cause? As advocates, doctors, scientists, survivors, and loved ones, we are counting on you. Now, as you all may know, my other job is being an English teacher. So unsurprisingly, I'm going to end with some poetry. In 2007, a group called the Cancer Poetry Project put together an anthology of poems written by survivors as well as their loved ones and caregivers. Here is a line from a poem in the anthology by Nancy Louise Peterson, a breast cancer survivor, whose piece was about reading bedtime stories to her young daughters. She wrote, "I need to tell you, I've learned both at the same time that time is limited and it's never too late. Our time together is precious and irrevocable. Getting this right for patients, for their families, for our entire community, ending the reign of terror this sickness has held for so long. This is urgent, but it's not too late. Together, we are stronger. We are fiercer. We are more powerful than this disease. We can save lives. We can protect those birthdays and anniversaries and New Year's Eve kisses. We can keep our time with each other if we act now, if we start today. So thank you. Thank you for being a part of this summit. To our medical professionals and researchers, thank you for the revolutionary work that you do every single day. To the family members and the caregivers, thank you for your incredible diligence and fortitude. And to the patients and survivors, thank you for your courage and your hope. Joe and I are with you every step of the way, because it's about time we created the kind of cancer support network that Americans deserve. It's about time we gave the fierce, courageous, relentless survivors a chance to share their victories. It's about time that we said, not one more mother, not one more grandfather, not one more son. It's about time. This is the urgency of now. And together, we will fight for the most precious thing we all have: time. Thank you.
Those were certainly inspiring remarks by Dr. Jill Biden. I can't imagine even a better place for us to be than all together here in celebration of what we're doing for the better cause. And we have a great panel, two panels actually lined up for you. I'd like to introduce our first panelist. And they're going to be in the panel Improving Cancer Outcomes, Priorities in Research, Care, and Prevention. Will our first panelist please join the stage? As soon as they're seated, I'll give you a brief introduction and we'll get to our first questions. And just as a reminder, for questions, please feel free to come to the podium and ask when the question and answer session opens up. And again, for those of you joining live stream, please feel free to submit your questions online as they come to your minds, and a member of our team will get them to our panelists. Thank you. Thank you. Thank you for being here today, and thank you for joining us on our first panel, Improving Cancer Outcomes, Priorities in Research, Care, and Prevention. I'm going to go ahead and introduce our panelists now. Our first panelist is Dr. Otis Brawley. Dr. Brawley is the Chief Medical and Scientific Officer for the American Cancer Society and a Professor of Epidemiology at Emory University. Dr. Brawley is a global leader in cancer prevention and control, as well as health disparities research. In his role at ACS, Dr. Brawley works to promote the goals of cancer prevention, early detection, and quality treatment, and eliminate disparities in access to quality cancer care. Dr. Carin DeSalvo currently serves as a professor of medicine and population health at the University of Texas at Austin Dell Medical School. She served as an assistant secretary for Health and National Coordinator for Health Information Technology at the U.S. Department of Health and Human Resources during former President Barack Obama's administration. Dr. DeSalvo has dedicated her career to improving the health of all people with a focus on vulnerable populations. Our next panelist, Dr. John Heymach. Dr. Heymach serves as chair of the Department of Thoracic, Head and Neck Medical Oncology at MD Anderson and co-leader of the Lung Cancer Moonshot, part of MD Anderson's Moonshots program. He's widely regarded as an international leader in lung cancer biology, treatment, and biomarkers, and is the foremost expert on resistance mechanisms for targeted therapies. Dr. Heymach has been instrumental in developing new therapeutic approaches to save the lives of patients with lung cancer. Dr. Katie Rizvani. Dr. Rizvani is professor of stem cell transplantation and also serves as the director of translational research in the Department of Stem Cell Transplantation here at MD Anderson. Dr. Rizvani is actively involved with MD Anderson's Moonshots program also. Her collaborative work has led the development of genetically manipulated cord blood-derived natural killer cell therapies, now in trials for hematologic malignancies, glioblastoma, and other solid tumors. Dr. Rizvani is committed to advancing novel cell-based therapies to the clinic to improve the lives of patients with a variety of cancer types. And lastly, Dr. Harpreet Singh. Dr. Singh is the president and CEO of Heymach US Incorporated, a clinical stage biopharmaceutical company active in the discovery and development of T-cell redirecting immunotherapies. He co-founded Heymach in 2000 and Heymach US in 2015. Since then, he has overseen all operations of Heymach in Houston, Texas, to develop next-generation adoptive cell therapies in close collaboration with MD Anderson. Dr. Singh is dedicated to translating pioneering scientific discoveries into highly innovative cancer immunotherapeutics with clinical utility. So please help me welcome our esteemed panelists. Now, without further ado, let's get to our first questions. I like to just pose this to all panelists. In your minds, what is the greatest opportunity you see for achieving meaningful cancer outcomes?
I'll start. There's two avenues, one being research, which we desperately need to support to find new treatments, new cures, new diagnostics, and new preventatives. And the second, and I think the low-hanging fruit, is applying what we already have. My group at the American Cancer Society noticed that college-educated Americans have a much lower death rate than Americans in general. That 32% of Americans are college-educated. We publish those numbers every year. We know that there's been a 26% decrease in cancer mortality since 1991, for example. There's 610,000 people who are going to die in the United States this year. If all Americans had the death rate of college-educated Americans, there would be 140,000 less. Nearly a quarter of all deaths would go away if we simply made sure that all Americans had all of the prevention, all of the screening, all the diagnostics, and all of the treatment that already exists. This is a logistical problem. This is not new science, not a new treatment, not a new screening test. This is just getting all Americans what already exists, and a quarter of all cancer deaths would go away.
Well, I will second that and just add that this notion of being able to not only prevent but have earlier diagnosis is a really essential way to reduce maybe even half of the cancers that we have in the country, or certainly the deaths. And so applying not only the screening tools and education more broadly, but really trying to understand why it is that some people are not able to either access screening or don't really understand the importance of early diagnosis. I think we've all had patients and family members who even if educated or even if they have insurance access, haven't felt comfortable going into the system for screening. I think what we're learning also is that it's not just about individual action. Therefore, there are some systematic changes that really help make access to prevention easier, and frankly just go all the way back to primary prevention. So I think in addition to seeing that people can get screened and have earlier diagnosis, we need to continue the movement to more broadly prevent cancer in the first place, whether that's from actions around UV exposure or smoke-free or tobacco-free policies, improving nutritional and physical fitness in communities. These are our actions that we all can take together that create a healthier environment so that our children are living in a community that doesn't cause them to have as high of risk of cancer, just as we're also working to see that people who should be screening and trying to prevent their own cancers through vaccines and through screening tests are also having access to that. But the last thing I just want to mention is about research, because I think we'll have a chance to talk about that a little bit later, but given what Dr. Biden just mentioned, I think it's important to also acknowledge what Dr. Brawley said, that we know a lot about what works, and I think making sure that we can break down those silos and make that more broadly available, and there's many opportunities we have using technology and data to do that much more effectively than we have been heretofore.
Very true. John?
Okay. Yep. Well, I certainly concur with Dr. Brawley and Dr. DeSalvo about the importance of prevention, but I'll talk briefly about advanced cancer. And so for many cancers, the majority present when the cancer is already spread. So how can we make progress there? And for us, I think the roadmap is becoming clear in certain areas. We're sort of seeing a spotlight into the darkness where areas light up. But I think the two major paths, and I'll use lung cancer as an example, are coming to a complete understanding of the genomics of cancer and the immune system and how it relates to cancer. And I'll just take people back a short while ago, and I see some lung cancer doctors and researchers in the field, like Dr. Mayran up there, who will remember, even 5 or 7 years ago, we really had nothing but chemotherapy for lung cancer. And lung cancer, is the biggest killer. And chemotherapy helped some people, but it usually added about a month or two of survival. And we treated everybody the same way. Everybody basically got the same chemo. We'd get in these giant arguments about what flavor of chemo, but none of it really made a difference. What we realized is lung cancer isn't just 1 or 2 diseases. You've got to break it into these little subgroups, these little slices of the pie. And we came to understand lung cancer really is 15 diseases, 20 diseases, maybe even more. Well, it turned out if we break one of those little slices off, we could actually treat that very well, often with pills or with the immune system. So in fact, for some of those little slices, just using a pill now, people go from 3 or 4 months survival to 5 years or longer in many cases. So in a sense, what we'd have to do is fill in more and more of those slices. But to do that, when people come in the door, they have to get their genomics characterized, and they have to get their immune system characterized. And that's the other major realization, that some people can respond wonderfully to different ways to stimulate their immune system. We have just the tip of the iceberg in terms of ways to work with the immune system. The 2 doctors you'll hear about next will fill in some of those other pieces. But when people walk in the door, that should be just part of the routine for everybody, that their genomics are characterized, their immune system is characterized, and then that data is collected. Doing it for 1 patient at a time isn't useful. It's useful when you have thousands of patients together. Now, often it's hard to get those things funded. Insurance might say, understandably, why should we fund all that profiling? We're only going to fund what's approved for that patient. But if that type work isn't funded, we never get there. It's the chicken or the egg. We don't learn about these subgroups unless that characterization is going on. So really what we need for that breakthrough is routinely profiling everybody up front, collecting the data, sharing it, analyzing it, and then taking on these cancers bit by bit.
Mm-hmm. Thank you, John. Dr.
Thank
Sani?
you. Well, I completely agree with my esteemed colleagues here, and I think it's very important to really understand the biology of cancer. I think once we understand the biology of cancer, and it's important also to note that different cancer types are very different in terms of how they evolve, how they interact with the immune system, how they escape immune recognition. And by understanding that biology, then what we can do is develop strategies that will allow us then to overcome that area of resistance. I think what is very important and what the Cancer Moonshot at MD Anderson achieved was to bring together basic scientists, translational scientists, and clinicians who understand the disease. And by bringing us all together, helped us develop strategies for individual types of cancer and individual subtypes of cancer, which then meant that we could develop a strategy that was very specific to the type of cancer that we were working on. As John mentioned, for instance, a subtype of lung cancer, or as in my case, being a hemoncologist, a subtype of leukemia, a subtype of lymphoma. And by targeting each of these separately, make major advances. And by bringing all of this together, I think we can get closer to our goal, which is to cure cancer ultimately.
Thank you. Dr. Singh?
And I couldn't agree more with Dr. Heymach and Dr. Rizvani. Cancer is not one disease, many diseases. I would take it even further, John. It's maybe not 20 different types of non-small cell lung cancer, maybe it's 100 different types. And so increased understanding of what makes cancer different is vital. Let me give you an example of what we do here at MD Anderson Cancer Center, which for me is the ideal place to really take personalization to the next level. We're running a clinical trial with the phase 1 unit with Dr. Timberay, where cancer patients come in. They're tested for 8 different novel cancer targets that we've discovered and validated together with MD Anderson. And they're screened for all these 8 targets, and then 4 different T-cell products, so adoptive cell therapy products, that are designed to match perfectly to the actual targets expressed and that patient are provided. So this is the first time actually we're providing multiple T-cell products to patients tailored to the individual expression of the patient. This has never been done before. It's the first time, and it's done here at MD Anderson Cancer Center.
Thank you. There's no doubt that research is essential for continued progress against cancer. For the panelists, what do you think are the key areas in which we should be focusing on?
That's probably the hardest question you're going to ask all day. I'm going to give you a slightly Washington answer and tell you that I think that we need to not focus too much on one particular area. For example, immunotherapy is incredibly promising, and we need to support immunotherapy. And for years, we did not support immunotherapy as we should have. But right now, I'm actually a little worried that too much emphasis is being put on immunotherapy and not enough emphasis is being put on some of the other traditional therapies. I think cytotoxic chemotherapy still has a place. Some of our precision therapies still have a place. And I'm worried, at least when I look at the newspapers, a lot of talk is going into immunotherapy. I'm even having patients who, very recently, for example, I had a patient that I was involved with, a young man who had Hodgkin's disease, who should have gotten ABVD, 85% cure of that. But he and his mother wanted immunotherapy because they heard it was so great. Now, immunotherapy is useful in treatment of Hodgkin's disease, but in the 15% of people who don't do well with the traditional chemotherapy. So I think we need to be balanced. We do need to be strategic, and we need to look at a number of different things. And I would also say research needs to be not just on treatment, but on how we actually provide prevention and treatment to the population.
It wasn't terribly Washington. That was good. I wanted to emphasize this need to study the sociology of cancer. And if the goal is to make cancer history, then you have to first prevent it. And so there's some systematic ways that I think we're beginning to understand you can change the environment in which people live and their behavior in that environment. Take tobacco use as a prime example that can help with prevention, but there's also sociology around early diagnosis or any diagnosis and treatment, and then cancer survivorship. And so as we move into thinking of population health opportunities, I would really love to see us as a country not just thinking about the biology, but also the sociology and leverage some of the new resources in behavioral economics and in technology and in big data to really see how we can mass customize and do precision public health.
Sure. So, to expand on the point I made before about sort of what we think are the twin pillars for treating advanced disease and possibly prevention as well, which maybe I'll talk about later, being enhancing the immune system and the genomics. And, there's been a massive investment that over the past decade or so that is really reaping enormous rewards, and I'll describe it a bit so you can understand what I think the next generation will have to look at. And this is the TCGA, or the Cancer Genome Atlas. And I think there's a very far-sighted effort where they said, well, let's characterize hundreds of tumors at a very, very deep level, make this available to everybody, make this a shared effort. And this will really give us the resources to sort of dig in and start analyzing tumors. And this is, just thousands and thousands of major breakthrough works have come from this collective body of information. Now, that was a case where these were all tumors that were cut out and didn't have a lot of follow-up data. But if you think of this as generation one of publicly available data that we all can draw upon, sort of a Google where we can really inquire about tumors, the next generation of that, again, is now moving this to advanced cancers where people are getting treated. What we would really love to have is that deep sort of atlas where people who are getting treated with cancers have the same deep profiling of their tumor, the deep profiling of their immune system in a way that everybody can access this data. And, this may be because somebody discovers a drug and they're looking around, who could this benefit? And a cancer they may know nothing about, they may just search and find out, look, this odd little cancer could benefit from it. And in fact, this is often what we find. Lung cancer is benefiting from a breakthrough that happened in melanoma about how to treat one little subgroup of melanoma. We've made an advance in a certain type of lung cancer that can benefit glioblastoma and cholangiocarcinomas. But a lot of this requires, first of all, making the investment that this profiling happens, even if the payoffs don't come right away. People have to be patient. The payoffs don't come a month after you do it. They may take 5 years or 10 years. And then secondly, in the infrastructure and the regulatory structures that let us pull that data together and make use of it. Lung cancer researchers are almost always willing to share and work together. There just has to be the infrastructure and the resources to be able to do that.
Thank you. Again, I'd like to state and kind of re-emphasize what I said in my previous comment, is that, the biology, understanding the biology of cancer is what is very important. So I agree, a lot of effort now is being put into immunotherapy, but not all cancers are susceptible to immunotherapy. So going with this attitude that immunotherapy is going to cure all cancers, ultimately I think is going to do disservice to our patients, because certain types of cancer are not going to be responsive to immunotherapy. They may respond to targeted therapies. And as Dr. Heymach mentioned, looking at these genome atlases, looking at the biology of the different cancers, trying to understand what is driving the cancer and the mechanisms of resistance is what is ultimately going to allow us to develop strategies that will work for our patients. So one example, for instance, is that hematologic malignancies are very susceptible to an immune-mediated effect. We know that because for 30 years we've been doing bone marrow transplants on our patients and curing 60% of our patients. During that time, 20 years ago, people started doing transplantation for breast cancer and for solid tumors, but that failed because the biology was very, very different. So understanding the biology and actually putting the effort into really getting to characterize different cancer cells and also their evolution, because as Dr. Heymach mentioned, cancer cells evolve. So once a patient relapses, their disease is going to be very, very different to what was there at the beginning, is what is going to help us develop strategies that will ultimately help our patients.
Thank you. Dr. Singh, would you like to comment?
There's hardly much to add more, but one area I think that's also very important is to make those novel therapies more affordable to broader cancer patient populations. Currently, targeted immunotherapies that we work on still have a very high cost of good factor. So working on those making more affordable, for instance, turning autologous cell therapies and allogeneic cell therapies, you can easily provide cells off the shelf like a drug, and also then in a timely fashion for cancer patients, I think is also an important area of research besides what has been said here.
Thank you very much. I'd like to open the floor now to questions from the floor or from our live stream. Does anybody have anyone have any questions?
Thank you. Hi there.
Go ahead. Hi. Good morning.
My name is Katie Jones. I'm the Executive Director for the American Lung Association of South Texas. I have a question where lung cancer, we know, is the #1 cancer killer of men and women. We've had an increase in the last few decades of women who are never, not current smokers and have never been a smoker, who are getting lung cancer. So when we talk about prevention, what can we do in a case like that where someone is not a tobacco user but they're still getting lung cancer?
Well, thanks. It's a great question. I guess I can talk about one aspect of this, at least on the lung cancer screening side. So the point you raised, I think, is a really important one, which is we know that smoking is associated with risk. And so the recommendations right now are just to screen people that are extremely high risk. And we have a criteria. You have to have smoked for so many years or so many packs of cigarettes before you get screened. But we're also seeing this rise in people that were never smokers, as you mentioned, who are getting cancers. The cancers that non-smokers get also have a different flavor than the cancers that smokers get. So smokers often have tumors that have a lot of mutations from all the damage that's been done by cigarette smoke over the years. Non-smokers, we believe it tends to be bad luck. A mutation happens, and it has a different appearance on the CT scan. Now, the appearance on the CT scan, if somebody happens to get a CT scan, is one where it's, instead of looking like a solid tumor, it's spread out like a little cloud. We call these GGOs for ground glass opacities. They're sort of a haziness, and these get missed by radiologists all the time. Radiologists say, I think it's a little, maybe it's a little bronchitis. People get an antibiotic. They go home, it doesn't really go away, and it keeps spreading. So my clinic is filled with people that present with exactly the situation. So we're doing a couple of things to try to tackle this. First is to develop blood tests that can detect cancer not only in heavy smokers, but might be relevant for non-smokers as well. One of the most promising approaches is looking in the blood for little bits of circulating tumor DNA that's shed, and also for some other protein markers. So Sam Hanash in our group has detected this. So in the same way for prostate cancer, men get a PSA checked. We're working to develop the equivalent of a PSA for lung cancer. But it's going to be a little bit more complicated because lung cancer comes in a lot of different flavors. The second thing is we're working on the situation I mentioned before where you've got these ground glass opacities. You know, a lot of these are at risk for turning into cancer but aren't yet cancer, and women or others with these are just sitting around waiting. Is this going to turn into cancer one day? So we're opening studies where we give immunotherapy. We basically use the immune system to see if we can prevent those from turning into cancer. So we're actually starting to treat people not with advanced lung cancer, but before they get lung cancer, but they're at risk because they've got these GGOs. And this is how we're trying to move towards a prevention paradigm there as well. But this is going to take some heavy lifting because the rates of lung cancer in non-smokers are relatively low, so you've got to screen a lot of people. But we're keenly aware of it, and thank you for raising that question.
I just wanted to acknowledge this tension that you're articulating, that we do know that there are many lives that can be saved with primary prevention and with early screening and diagnosis. It doesn't solve all of the challenges that we have, and so it's not an or, it's an and. We have to find ways to also make sure people have access to high quality treatment, and then when they're survivors that they have support in that phase as well. Thank you.
Thank you. Thank you for that question. Next question.
We have a question from our virtual audience. Can you speak to any updates on CAR T-cell therapy?
So, as I'm sure you've all heard, and it's been all over the news, the CAR T-cell therapy targeting lymphoid malignancies, the data have been really incredible, especially in childhood acute lymphoblastic leukemia, but now also in non-Hodgkin lymphoma. We expect that there will be approval for chronic lymphocytic leukemia. There have been very interesting data also presented for CAR T-cells against multiple myeloma, and we expect to receive FDA approval for that indication soon, later in the year. CAR T-cells, however, I think there are two major challenges that need to be taken into account. One is that the results of CAR T-cell therapies for solid tumors has been less promising, and that's partly because solid tumors are much more complicated in terms of their microenvironment. They have a lot of strategies that allow them to escape the engineered T cells. But the other, I think, very important point that Dr. Singh brought up in his previous answer was the issue of cost. So CAR T cells are extremely expensive, with a price tag ranging anywhere from $375,000 to $475,000, making it very unaffordable for many of our patients, and also problems with getting insurance approval. How is Medicaid going to cover it? How is Medicare going to cover it? So developing a strategy of a product that could be off the shelf and that can be produced to treat multiple patients, as opposed to a very patient-specific product, is going to be crucial for this treatment to be available and to help many more patients. And at MD Anderson, that's one of the major focuses of our research. With the help of our Cancer Moonshot program, now we've developed, and actually also American Cancer Society, we have now developed a strategy that allows us to manufacture off-the-shelf product, which is significantly cheaper, and that's currently in the clinic with very exciting initial results.
Thank you very much, Dr. Asfani. Okay, question in the back.
Hi, Carin Hagberg from the Department of Behavioral Science at MD Anderson. Thank you all for being on this great panel today. I want to bring us back to prevention and applying what we know. It strikes me that, I keep seeing studies in the literature, for example, that show us that certain methods for improving cancer screening rates are shown to be effective in randomized controlled trials. So there was just a recent trial on reminders from the healthcare system, and when these are provided to patients, it increases screening rates, yet it seems that healthcare systems are still not doing things like this, or not providing smoking cessation services, or not providing weight loss services, despite the fact that these are evidence-based services for improving health and decreasing the rates of cancer. So what are the levers that we have as, governmental levers, or cancer center levers, or population health levers to influence healthcare systems to provide these things and for payers to reimburse for them?
One of the reasons why 18% of the American gross domestic product goes into healthcare, and the average in the Western world is 12%. And by the way, the other countries in the Western world have lower cancer death rates than we do in the United States, is we do not have a healthcare system. To call it a system is an affront to the word system. It is by no means organized. We waste, by the way, in screening, we waste a lot by doing screening that we shouldn't be doing, screening that can actually be harmful. And so it's not at all organized, and it's not at all a strategic approach. And what you're calling for is what is absolutely necessary, a regimented system. Sometimes you actually see this in places like the Kaisers and the HMOs, where they actually by computer keep track of whether or not someone has gotten appropriate screening. And they make sure that women only get screened every 3 years for cervical cancer and not every year. And they make sure that if a person doesn't get a mammogram in their 50s and 60s when mammography really, really works, they get called back and they get pestered to get the screening. And we waste a lot of efforts with screening tests, again, that don't work, and screening tests that can be harmful. And then don't get me started about cigarette smoking.
Oh, I can't resist, Carin. I know you're doing a lot of really great work with communities in Texas, and agree completely with Dr. Brawley about the lack of systemness. Those populations that are part of more coordinated care systems, those kinds of systems that he mentioned, some Kaisers or integrated delivery systems that have financial downside risk for the outcomes of their patients. That's very Washington-y, wonky. Sorry, but there's an incentive in the healthcare sector to do more and to be financially rewarded for that. But what you see in the data as those incentives change, and it's really about improving health or maintaining health, that they develop strategies, those systems, to bring people, to alert people to screening, to fill gaps in quality, and they also increasingly do, as MD Anderson is doing, work with community to not just change the incentive structure and the awareness, but really change the context and the culture that drives this idea around prevention.
Yeah, and let me just add some additional practical considerations around the incentives. Healthcare providers are getting busier and busier, being asked to do more with less time, and the way they're incentivized and the way that they're reimbursed very little for conversations. They're reimbursed very little for discussions with patients about preventative things. They're reimbursed significantly more for procedures for things. So if I'm an oncologist and I'm treating somebody who's had a lung cancer cut out, we know that they still have a major risk of developing a subsequent lung cancer, even if we cure the first one, and that's much higher if they smoke. So one of the most important things that I could do, rationally, would be to have a discussion and refer them to our wonderful tobacco treatment group here that does this cutting-edge stuff. But that takes a lot of time, and until I became aware of it, my own knowledge about smoking cessation tools was back from, medical school in the early 90s, and, it was basically tobacco patch and Chantix. There was not a systematic investment in teaching physicians about how to prevent smoking or how to help people quit. We don't invest enough in our quit lines to make these tools available for everybody. Patients often have to pay an enormous copay for things like Chantix, which helps people stop smoking. So we're not incentivizing either the healthcare system or patients to do the things that's efficient for the whole system. Everybody agrees getting them to stop smoking, is better for everybody, but we're not structuring our incentives to make that happen.
Thank you very much. Question?
One of the things that I've come across a lot of times when we're treating our patients is that they'll be on immunotherapy, chemotoxic chemotherapy, things like that. And they'll be having some sort of response for a while, or maybe they'll be in stable disease over like 6 months. But then all of a sudden we hear like the cancer evolves, it mutates, and it takes a different pathway, and then they progress and they have to be treated on something else. So like constantly these patients are on new things, I just kind of wanted to know like what kind of research is kind of going on into really figuring out how can we be like one step ahead of these cancers and understanding these. We have all the biology about their pathways, right? So like how could, I don't know if it's like their algorithms or something, like what are we doing to really stay ahead of the cancer and kind of be more predictive about, hey, this is where the cancer's, what it's doing now, where is it going to go next?
I can at least talk about solid tumors. I mean, what you described is a very accurate description of what we face every day in the clinic, that we might have a therapy that works for 3 months or 6 months and we're excited that it works, but the tumor starts growing again. And, if we look at diseases like HIV, the way they made progress wasn't doing one drug, waiting until it failed, doing another drug. They learned the different ways that the virus could mutate and then did combinations up front. But we're often limited in combinations because it's hard to get combinations FDA approved. And often these drugs are toxic and it's hard to give combinations. What we're trying to do is collect the information when patients progress, because we know depending on the drug, there's a lot of different ways their tumor can evolve. I'll give an example. There was a type of drug called an EGFR inhibitor we used for one subgroup of lung cancer. And when we started using the first generation drugs, most tumors did one thing. They had a new mutation. And we developed a drug that targeted that mutation, and now the tumors start doing 10 different things, and you never know what they do. But so we're trying to develop studies that give us flexibility to cover all of them. But it takes an investment and funding to analyze what happens at progression and, again, collect that data. That's often the biggest limitation, is biopsying the tumor when it grows, analyzing it isn't covered by insurance in many cases. The data isn't aggregated in a way everybody can access it. So part of what the system can do is make that easier for that data to get aggregated. And, I hear a lot about, well, there's privacy issues and so forth. I can tell you that patients are shocked when we talk to them about how hard it is to get this data together. They say, we want all this data collected and used the best it can.
Just to add to this, how this can be practically done. So together with John Heymach's department, we're currently doing trials in lung cancer, not just with one type of CAR T-cell therapy, but actually 3 different types. The third one is just about to be proved. And so in biopsies that Dr. Heymach's department provides, we check sort of the existence of these targets, apply the respective therapy, but then in serial biopsies, where you go on, you can actually check other targets evolving. Is there something we have in our arsenal that we can apply to? Now, these are just 3 CAR T therapies. What I envision is that we'll have 10, 20, 30 of these. So testing these patients meticulously is very important, but also building an arsenal of targeted therapies. Within cell therapy, that's what we're doing, but also, as Dr. Rizvani said, outside cell therapies and immunotherapies.
Thank you very much. I can take just the last question, and we'll make our responses fairly brief so we can continue with the program.
I appreciate it. My question is more in line with cell biology and also with drug development and with research. Out of just curiosity, the basic understanding about cancer, the way commonly treated is through chemoradiation. So wanted to know within research, what is the work that is being done or in the process of continuing where when when a person is exposed to chemoradiation, all the cells die, the good and the bad. Is there any way there would be a stain or a dye or a capsule that encapsulates the good cells in less exposing to the radiation, or really making only focused on the cells that we want to treat, not the good and bad cells, so that the patient is not going through severe effects of radiation? And I hear most cases it worsens the patient's situation and the condition where when they are exposed to the radiation, they go to the extreme, no immune within the body, and their disease within a couple of days or weeks, nature of cancer.
Well, thanks for your question, and we're lucky enough to have here some real leaders in radiation that could give much more detailed answers. I saw Dr. Kung in the back before, and others from the radiation group. I can mention two different approaches that we're trying to make radiation do a better job at killing the bad cells and spare the healthy cells. Our radiation group is pioneering different types of radiation. One of them is proton therapy. And the way I'd explain proton, normal radiation, what we call gamma rays, scatters. So if it hits the tumor, it may kill some number of cells, but it scatters and hits normal tissue. Proton is shooting little particles, and they can control exactly how deeply they penetrate and prevent them from scattering. So to give a wonderful example, you can give radiation to children who have tumors on the back of their retina. You can radiate those without the beam scattering into their brain. Just give an example of how precisely they can stop that beam. So I think that's wonderful progress. But the second side of that is we're learning we often don't need to have to give high doses of radiation. Part of what radiation is often doing is stimulating the immune system, and sometimes less is more. There was a big lung cancer study where they tested a high dose versus a low dose, and they were absolutely sure the high dose was going to be better. And the low dose turned out to be much more effective, and everybody thought they had switched the curves and thought that, and they started blaming each other that they were given the high dose wrong, before people said, well, maybe the result is actually right, and maybe the high dose was wiping out too much of the immune system. So I think that's the radiation group, and I can speak about our group here, is really doing cutting edge work to tailor it, make it cause less damage to normal tissue, but also use the body's own defenses to help fight better with the immune system.
Thank you very much. In the interest of time, that will conclude our first panel session. Thank you, expert panelists. Appreciate all your advice. Thank you to the audience. I'd like to now go ahead and bring up our second panelist to the stage. And this panel is going to focus on the patient experience, improving access, navigation, and survivorship. So please, our second panelist, come on up to the stage. And once again, I'll go ahead and provide a brief introduction and tell you about our great panel that we have before you this morning. So, welcome. Welcome, everyone. Okay, I am honored now to introduce our second group of panelists. Let's see, we start Dan Blum. Okay, Dan is a native Houstonian, a passionate patient advocate, a member of MD Anderson Advanced Team, our next generation board of business and community leaders, and a thyroid cancer survivor. Jennifer Kennedy-Stovall. Jennifer serves as Director for Patient Access Support Services at MD Anderson. She's been at MD Anderson for more than 16 years. working closely with patients and their families in a multitude of focus areas, including health information services, public education, and Ask MD Anderson, the institution's front line of knowledgeable staff who interact with patients first upon diagnosis. Dr. Alyssa Reber. Dr. Reber serves as chair of general oncology at MD Anderson, where she facilitates the clinical and academic medical oncology programs at MD Anderson's Houston area locations, the MD Anderson Medical Oncology Program at the Lyndon B. Johnson General Hospital, and at MD Anderson's International Cancer Assessment Center. She has spent her entire career at MD Anderson, joining our faculty in 2008 as a clinical assistant professor and working her way up the ranks. Dr. Reber is also a proud cancer survivor. Damian Smith. Damian Smith is a throat cancer survivor and MD Anderson patient advocate. He's passionate about sharing his experience with other cancer survivors and encouraging throughout their entire journey. And finally, Dr. Wellela Terefa. Dr. Terefa serves as MD Anderson's Chief Medical Officer. She has been a leader in local patient access and in safety and efficiency initiatives, including standardization of treatment planning schedules and creation of a daily division-wide safety and operations briefing. Dr. Terefa's work focuses on educating providers about regional and national shifts in the healthcare environment and their implications for MD Anderson. Please help me welcome these passionate, esteemed individuals, cancer fighters, here before us today. Okay, now let's get to our questions. For the whole panel, and it doesn't matter what order, just please speak up. What are the biggest challenges facing patients, caregivers, and family members beyond the physical ramifications of their disease?
I would say the first and foremost has to be financial toxicity, which is an issue of major concern for insured people as well as uninsured people, particularly because our society links insurance coverage to employment status, and a diagnosis of cancer puts employment at risk. Just the frequency of visits for treatment can cause friction between an excellent employee and their employer, and despite a variety of legislations in place to protect people when they have a diagnosis of cancer, FMLA, the ADA, many of our patients are fearful that the necessities of going through treatment will put them at risk of losing their jobs. Even when they are able to maintain employment and insurance, there are additional costs that are not covered by their insurance that can really pile up. There are the costs associated with treatment that we don't necessarily think of that can become really tremendous. Just the cost of parking when you have to come in 3 or 4 times a week for treatment can be tremendous. If people are in the sort of trajectory portion of their career, there's a lot of fear that they'll miss out on opportunities for growth while they're under treatment for 6 months or 12 months, and that their position in their place of employment will be compromised indefinitely. And I think all of those things add up to an experience above and beyond everything that's associated with the physical experience of having cancer that is incredibly wearing on patients, and that does not end after they finish their active cancer therapy. Many people are dealing with the financial ramifications of their diagnosis and their treatment for years afterwards.
Yes, I would. There's numerous challenges that patients face, unfortunately. As Dr. Terefe said, the financial burden is huge. Also, the ease of access is something that is a problem from the very beginning. Just finding the right access. It's so incredibly important for cancer patients to be seen by the best specialist for their type of cancer from the very beginning. This is especially important for our rare cancers or our less common cancers. And this is not an easy thing. This is hard for patients who live in smaller communities and rural communities, because along with that comes the financial burden of trying to get to the hospitals that may be able to best serve them. So, this is something that it's very difficult, especially when they're going through the emotional and physical challenges that come along with cancer.
First of all, I just want to thank you guys for having me here. I would kind of piggyback on what both of them said about financial and just the ease of access. I was very blessed and fortunate to be, I live in Missouri City, which is right up the road from here, so I just hop on the freeway and get here. But just in my little circle of friends and family, probably about 10 people have been affected by cancer. And for me, I would always say, oh, are y'all coming to MD Anderson? Because, everybody in Texas figures this is the best place to be. But it didn't dawn on me that this type of care was available for everybody. So it's a burden for some people who might live out of town. Like, I'm originally from Waco. One of my friends, the idea of them coming all the way to Houston to get cancer treatment was just, it's mind-blowing to them, because they figured the traffic, how are we going to eat, where are we going to stay, how long we're going to be there. So I think that's one of the things that the challenges that cancer patients face as well.
Well, I definitely agree with everything that has been said. I would also like to start from before the diagnosis of cancer and what barriers people face. We have a lot of patients who know that something's wrong but don't know how to get diagnosed and don't know how to get to a doctor. I am fortunate enough to work within MD Anderson's oncology program at LBJ and Harris Health System, and so I see every day, as others do here, that patients have had challenges just getting diagnosed, and then once they get diagnosed, trying to get access to the right care at the right time is also a challenge and a frustration. And that's not only a physical frustration, it's also emotional, spiritual, and psychological. And so I would say that anytime someone is diagnosed, it is the whole patient who is affected. So it affects their pocketbook, it affects their mind, their body, and their well-being. And I also would like to say that it's not just the patient diagnosed, it's the whole family going through that journey. And a lot of times whenever you have patients who are experiencing distress, a lot of that is not necessarily related to their own diagnosis and the physical aspects of that, but it's related to family stressors, the financial toxicities, how to talk to their children about this, how to arrange for life to continue to go on in that household while they're facing this terrible journey ahead. And so that, I think, is one thing that sometimes is not addressed during those initial visits or those initial discussions of the cancer diagnosis.
Yeah, I think it's interesting because everybody's journey is so different, and everybody has a very different approach to how they mentally approach cancer. Some people just want to they don't want to think about it. They want to fully trust their doctor, whether they're at a major cancer center, at a smaller hospital. I think clearly most of the people in this room fall on the other side of the spectrum, where they want to get access to as much information as possible, and then it gets overwhelming because you're on the internet scouring. You have no training in this. You want to trust your oncologist, but deep down you want to have control over the situation that's not necessarily controllable. So I think anybody who's an MD Anderson knows that at least they've taken that fear away of wondering if their doctor, for whatever cancer they have, generally your oncologist has seen more of that cancer than anybody else in the world. So that takes a lot of the stress off the plate, but so few people who are diagnosed with cancer are at an MD Anderson or a Sloan Kettering. It's how do you get to the last panel's point? How do you get information to these smaller hospital oncologists or general practitioners that they can't link? They can't necessarily link symptom A or procedure A and B to, all right, this means this patient's got a 60% chance of having cholangiocarcinoma. I mean, it's just, I just throw that out. That's what my mom had. And it affects 6,000 people a year in the U.S. So it's, unless you're at an MD Anderson, you're not, and then you start digging in and trying to do the research yourself, it just becomes so overwhelming that it's difficult.
Thank you very much. I think that can lead right into the next question. What prioritized services do you think could be provided to patients to help them navigate through their cancer journey?
I can start. And when we talk about the needs of our patients, it's the needs of our patients, their family, caregivers. Like Dr. Reber said, this affects the entire family. Cancer is a family diagnosis, and this affects them emotionally, physically, and unfortunately financially. And what our patients and their support team need most through the journey, the continued need, is information. They need access to information. They need to know about their cancer. They need to know what their treatment options are. They need to know about clinical trials, what clinical trials are, the importance of clinical trials, what clinical trials are appropriate for them. What support services are available for them. Not only do they need this information, but they need it specialized and specific to them. There's so much information out on the website, it's overwhelming for patients. The entire experience from the moment that they are diagnosed or a family member or a friend is diagnosed is overwhelming, and the urge is to go out there and start to look for information. But we need to provide services that allow them to get this information that is specific to them, and not only specific to them, but when they need it. Cancer is not an 8 to 5 diagnosis, and we have to stop offering services and these informational services just during those hours. MD Anderson has recently expanded the hours for our informational call center to allow patients access to this in the evenings and weekends. And then we have some other incredible services for patients that many other hospitals also have, but the Learning Center here at MD Anderson offers patients the ability to talk to specialized educators, librarians who could help them with information on their cancer and resources for them, for their care team, for their support team. My Cancer Connection is also an incredible resource for patients. So I actually match patients and their care team up with other survivors and other patients who understand what it's like. They have a unique perspective, and they're able to provide that one-on-one support. So offering this information, making sure that patients and their families know about these services is incredibly important.
I want to just reemphasize that statement about the importance of education in a manner that patients can understand at their health literacy level, and trying to increase health literacy. There is a lot of misinformation available on the internet, and so trying to make sure that we can direct people to accurate, safe sites on the internet that are not anecdotal and that are not going to point people in the wrong direction, I think is incredibly important. So I give a limited number of websites to patients and their families, and really try to direct them towards trusted sites that are vetted by science and physicians and educated people who are part of the cancer team.
Yeah, one of the things I would add on is that what you guys really do here well is exactly what Jennifer was talking about. When we walked in the room, my wife and I, they told me exactly everything that they were going to do to me. And I was in the head and neck department, and Dr. Myers, they said, well, we could do a trach, and I started crying because I was like, no, man, I don't want you to cut on me. He was like, no, that's just an example. But he told me basically every option I had. And so I told him, I was like, the less you can cut and poke and prod on me, the better. But that's what we loved about it, is that they told us everything. And if somehow you guys can take the approach that you have here and share that with the smaller communities and help these smaller people, smaller hospitals and smaller health organizations, I think that would be a big benefit, because I left the room feeling like, okay, let's go. When do we start? As a matter of fact, they called me and they pushed it back, and I was like, why? Let's, and my wife was like, slow down, and I was like, no, let's go, and it was just a big help to be that in a place like everybody was comfortable. They walked in, they knew what they were doing, and so that was a big help for me.
I can't tell you how happy it makes me to hear you describe your experience that way. That's exactly what we want to be at MD Anderson for all of our patients. And just building on that theme about navigation during the treatment decision-making and care coordination period, because we really need to help our patients navigate all the way from screening and prevention through survivorship. But that piece is something that I think MD Anderson does incredibly well because we have multidisciplinary centers. And so rather than requiring our patients to cobble together a treatment plan from 3 different visits that might happen over 3 weeks with 3 different experts who might say things that are contradictory to one another, we have in many of our multidisciplinary centers coordinated clinics where all within the same few hours or within the same 1 or 2 days, patients meet doctors who discuss with one another what the plan should be so that they can present a coordinated set of recommendations and take the burden off of patients for understanding what their options are and then for connecting with the right doctors for carrying out those treatments. And I think that is the kind of thing that we want to disseminate around the world, not just to Texas, but to the rest of the nation and to the rest of the world. And I'm really grateful for our leaders who are building our MD Anderson network with partners in community hospitals as well as larger hospital systems throughout the United States to help them build those kind of cancer care, coordinated cancer care operations that really benefited you and benefit so many of our patients.
Would you like to comment?
I was just going to say, and that's huge. I mean, I think what MD Anderson, or at least the doctors that we interacted with in my mom's journey and mine, was the openness to, if we did have a question about an alternative treatment or something that wasn't part of their standard procedure, that I could ask the question and the answer might be, I don't know, but I'm going to go talk to my colleagues and we're going to research this and we'll come back to you and, with a recommendation. And what stinks is that if you're not at a place like this, you're not going to get that kind of reaction. It's going to be, that's dangerous, you shouldn't mess with it, as opposed to, hey, let's figure this out.
Great. Thank you so much for sharing your stories and insight with us and expertise. I'd like to go ahead now and open questions to the floor. Please, there's microphones in the aisles. And also for our virtual viewers, please submit your questions online and we'll be happy to answer them. Go ahead.
Good morning. Chris Hagerman with Patient Experience. Talking about access, I routinely talk with patients who cannot come to MD Anderson either through insurance contracts or just the distance. I think one thing that MD Anderson has really helped is with our Houston area locations that allow people to get care closer to home so they don't chip away at FML, so they can go back and be with families. I've also, my question though is, MD Anderson posts treatment algorithms on our public website for treating physicians. Do you find that physicians who are not part of the MD Anderson network but who are in the community are embracing that or really taking advantage of that information that's out there? Because I've provided that to patients before who can't come. I'll say you might want to talk to your doctor and use this as a basis for discussion. So do you find that that people are receptive to that?
I'm happy to take this one. In regards to the treatment algorithms, I think that it is not widely known and not widely adopted. I think when you look across the nation and look at smaller communities and other physicians, most oncologists go to the NCCN website, so the National Comprehensive Cancer Network website, with their algorithms, which MD Anderson's algorithms are very closely in line with, but there are nuances. The great thing is for every panel on the NCCN, MD Anderson has representation, and the NCCN is a group of experts who come together on every disease type, every topic, and so we're able to be at the table to provide our thoughts and our approach whenever we're discussing the best way to approach breast cancer per se. We have that representation and are able to share our experiences. There's what's called level 1 evidence, so the most strongly supported by data, but then there's a lot of nuanced care that is discussed and debated in those conference rooms, and we're at the table and we are influencing the care that is widely accessed not only in the United States but also throughout the world.
I would add that our network partners do make a commitment to practicing in a way that's consistent with the MD Anderson algorithms, and they do pay a lot of attention. When we make minor changes, many of us, in our respective disciplines, get contacted by network partners for education or assistance with implementing a new algorithm, or just to get a background on why something changed. So I think that those algorithms do have great penetrance there. And we have a really robust system for assessing quality and compliance and concordance with practice with our network partners, which is, I think, a very powerful way to extend the MD Anderson quality of care to people who cannot, for logistic or other reasons, travel to MD Anderson. We want people to be able to get MD Anderson care wherever they are.
Any further comments? Or we'll go to the next question. Okay. Oh, I'm sorry.
Hey there, my name's Heather Alexander. I work in community relations and education. I also have had 2 family members come through MD Anderson as patients. And it seemed to me that there are quite a lot of resources here that patients that are underused around exercise, healthy living, social work, all the emotional, psychological support that we offer. How can we encourage patients to break through the fears that they might have and ask for more help? Because I think that there is more available here for many people.
I'm going to jump in and say I think we should take the burden off of patients for asking for it, and it should just be part of the standard set of things that we do when a new patient comes in: a social work consultation, a consultation with supportive care, a visit with our integrative medicine center. If we just schedule those things the same way we would schedule some blood tests and an imaging study, patients will go and then they'll benefit from the services that we offer. I think the key is to reduce the friction of having to actually ask for and reach out for those kind of services. Many times patients are not even at a place where they can think about those services at the moment that they're diagnosed. And more of our centers are building sort of standard sets of interventions that happen for everybody who meets certain criteria, right? Are you newly diagnosed and your BMI is above 25? We will refer you to the Integrative Medicine Center so that you can learn about weight loss and healthy eating and exercise from them. Are you expressing distress when you fill out your initial evaluation? We'll not only make sure that you visit with our social worker, but we'll advise you about other services in our Integrative Medicine Center for stress management, and we will provide you services to help talk to your children if you report that you have kids who are of minor age. So I think it's really about us making that just part of the package of what happens when patients first come on our campus.
I'd like to just piggyback on those comments. I absolutely agree we need to take the burden off of patients. They are dealing with too much. What's important is giving them what they need at the right time that they need it. And looking at, is this a newly diagnosed patient? Is this a patient that is coming to us having had some sort of treatment and has an understanding about what the journey looks like a little bit more, and determining what those services are for that patient and when, and utilizing their support system. Many times we can share this information with their caregivers, and they can be the ones to really help patients determine, this is the right time for you to get this information. Let's seek out this information, because the patient just may not be able to take in all of that information at that time.
Yeah, I would agree in that if we did all of this up front for everybody, they could be quickly overwhelmed. And so I think, to your point, when people need resources and we have them, trying to navigate that piece can be tricky, because there can be stress on the patient. Well, should I go to the nutrition appointment and learn what I should eat, or should I go get my CT scan, because they're similarly placed? And I think that we've done a lot better job of scheduling patients' appointments and trying to be mindful of their time and bringing people to them, and also having more access to things on the website, things through my chart, those types of things. I think that we're we're just now getting to where we can coordinate this better for patients and their families, and it's very exciting to see trying to just link everyone together. And I think that the experience that people had before is not the experience that they're going to have now and in the future. We're doing a great job of being patient and family centered.
The one thing that just kind of popped out of my mind when we were all talking about this was the first day here is like very intense, right? You can, I mean, we went home and we slept for like 2 hours because it was like a lot of information, right? And then as I started treatment, like you can pick out when it's somebody's first day, right? Because they got their little packet, they got their MD Anderson packet folder, and their eyes are this big. And I distinctly remember talking to one young man, and he was with his mom, and you could tell like they were a little distressed. And you know, by this time I think I'm like an MD Anderson vet, right? So I'm going to go up to them and be like, "Hey man, it's going to be all right. Like you're in the best place in the world." And like he wasn't really receptive to it, you know. Like everybody's not like me; they're not like happy-go-lucky. Hey, let's go have a party. But this guy was kind of standoffish, and I had to realize like it's true. This disease affects people in different ways. And the one thing I wasn't prepared for was the emotional part of it, right? Like I can do all the physical stuff. I'm a big dude, you know, like bring it on. So the issue I had, and my wife's gonna kill me because I never told her this, was that I felt super guilty about putting my family through it. You know, like my mom had to come down. You know, my brother had to take a day off. I had a little girl at the time. I said I wasn't gonna cry. Anyway,
I'll cry with you. It's okay.
I had a little girl at the time, and I just remember she remembered this part, like she fixed me a bowl of soup or something. And I was trying to go to work every day. I didn't miss a day of work, and that's a testament to you guys' job. But one day I got a little tired, and just for y'all who some of people know, I'm a television cameraman at Channel 13 here in town, and I was on a high-speed chase, right? So my adrenaline's pumping. I'm like, you know, bad guy, cops and robbers, whatever. I jump out the car. I got my camera. It's hot. It's summer, and I just couldn't get my legs under me because I'd done chemo 2 days before, and so I couldn't get my legs on. I called, and they're like, "Yeah, just go home. You know, go rest." And so I was eating, and I just started crying at the table. And she's like, "What's wrong?" I'm like, "I'm good, nothing." And but in my mind, I was like, "Man, I just hate I got to put y'all through this." And then 2 days later, it was a story on 60 Minutes about this lady who'd done all these clinical trials. She's like 60 years old, and she ended up passing away. And I like ran to the bathroom, and I just like cried in the bathroom. I'm like, you know, why did that lady not make it, and why was I still here? You know, so I think that's like one of the biggest things I could tell you guys is maybe not do all the emotional stuff up front, but like look at your patients as they're going through it. Because by the 5th week, you know, week 1 through 4 of radiation and chemo, I was good, man. I was like, the only thing I was worried about is losing my beard, you know, seriously. But by the time they told me, like, hey, man, around the 4th or 5th week, you're going to start feeling this. And I did. And that's when I was like, I started feeling guilty and, you know, started tearing up and stuff, soup and stuff. So anyway, that's my input on it. So
We have one last question.
Thank you, appreciate. I'm a caregiver of cancer patient and also community member. My question, since we have this chief medical officer and chief academic officer, maybe for you both, I feel very lucky that Houstonians have MD Anderson here in Houston, so people in Houston have easy access here. But in America, not everybody can get here, not mentioning over the world. MD Anderson is the #1 in cancer, so people from all over the world are coming here. So I helped some Chinese patients coming here and to get treatment. But if there's only one place to go to get cancer treated, obviously it's too expensive and people will not be able to get here. This may not be a good analogy, but just like a McDonald's, you know, if you want to have McDonald's, there's only one headquarters to get that authentic hamburger. It'll be too difficult, right? So McDonald's actually is every corner in America and every corner in China, in England, right? So what is the thinking about maybe duplicate, you know, MD Anderson treatment kind of model may not be like every corner like McDonald's, but maybe other country or other regional center in America, something like that. What's the thoughts of that? But I talked to some doctors and they say, oh, we have one, maybe have one in Madrid, like Spain, and then saying, oh, it's not the same as MD Anderson. What is the secret? Is it because it's in Houston or the location? Can you think about like a education program to treat, to teach some people and then have some, bring them here, just learn the secret? I mean, it'd be more complicated than making hamburgers, but maybe there's a way. I mean, MD Anderson people go other place, and then there are new people come to MD Anderson, not necessarily graduate from MD Anderson, right? They learn it here. What is the secret to get there so that we can really eliminate cancer in America, in everywhere?
Well, thank you very much for that question. I'll just say a few comments and then hand off to Dr. Willella. But you're right, we have the secret sauce here. There's no doubt about it. And a lot of it comes from those in the audience and our panelists. But we are trying to reach out more. We have a network. We've established more Houston area locations. And that is the plan, is to try and get ourselves out more. So we do have a number of programs that are over actually in China. We have several sister institutions. But you're right, it's hard to do everything, every place just exactly the same and get the same results. But we're trying, and we really are trying to do just that. But I'll let Dr. Terefe go ahead and maybe make a few more comments.
I don't think I'm going to be able to work on McDonald's analogy, but I'll try. On the one hand, yes, we have a secret sauce, and on the other hand, there are clearly defined best practices for cancer care that we feel a strong responsibility for disseminating outward. And so probably the first level of dissemination is with our Houston area locations. We currently have 4 Houston area locations, but I'm sure the future will expand beyond that. Those are, that is part of MD Anderson's Cancer Center. We are a single cancer center with 5 campuses. Most, if not probably all of the staff and faculty working at those Houston area locations either trained at or worked at the Texas Medical Center campus of MD Anderson, and so we really are one single campus, and that provides better access to patients throughout the Southeast Texas region, where we're working to expand the MD Anderson-like care throughout the state of Texas is in partnership with our UT colleagues. We just went live with a huge new collaboration with UTMB. Our League City facility is a place where our physicians will co-practice with physicians from UTMB, and we'll be able to provide extended care to patients who otherwise would have had trouble coming into this area. We are working on building relationships with UT San Antonio and UT El Paso. Most of the UT system, we hope, will one day, not too far from now, be able to provide MD Anderson-like cancer care to Texans where they live. Outside of the state of Texas, we have robust network relationships that have been established for some time now in the Northeast. We are building great relationships in the Southeast. MD Anderson Baptist in Orlando just opened up a fabulous new cancer center, and we've been partnering with them. We are spread out to the West Coast also, Scripps MD Anderson Cancer Center in La Jolla. And those are organizations that have committed to practice the way that we do, and we are pouring resources bidirectionally for prevention, treatment, clinical trials, and survivorship. On the international scene, it's a little more complicated, but we do have a robust set of relationships with sister institutions throughout most of the globe, including in China. And we also welcome patients from abroad to MD Anderson, and we're working to strengthen the quality of the services that we provide them where they have unique needs related to language needs, cultural needs. I am always amazed that people have the courage in the midst of a cancer diagnosis to come halfway around the world to a place they've never been, where people don't speak a language that they know or eat the food that they eat and go through cancer treatment. And so we really want to focus on elevating the care and navigation that those particularly vulnerable patients need from us.
Okay, thank you very much. In the interest of time, I'm going to conclude that with questions. I would like to just thank everybody. I'd like to thank our panelists here today on our second panel. I did a phenomenal job. Thank you. So I'd just like to conclude on behalf of the physicians, the staff, and patients of MD Anderson. Thank you for spending your morning with us. It's certainly been a lot of good stories and excellent expertise and knowledge that has been shared with us this morning, but really in hopes to bring us closer to a world free of cancer. Our collaborative efforts here in Houston, across the nation, and all over the world are leading to meaningful, impactful changes. And thanks to you, MD Anderson and other academic institutions, as well as cancer care centers, can continue to push the boundaries and change the face of cancer care. Together, we can make cancer history. Okay, lastly, just one last comment. Please don't forget to log into your computers this afternoon. You'll hear former Vice President Joe Biden's live address at 3:30, and you can view it at bidencancer.org/summit. So finally, please be sure to fill out and turn in your response cards, and we'll share your feedback and ideas with the Biden Cancer Initiative. Thank you very much, everyone. Enjoy the rest of your day and your weekend to come.